All right, good morning. So this is the first of our Grand Round series for the 2014-2015 year. So I'm pleased to introduce Dr. Erik Ranheim. I met Erik just over 10 years ago. He came and spoke at the M.D. Ph.D. retreat here. So Erik is from Minnesota. He went to Penn for his bachelor's degree, came back, and it was part of our M.D. Ph.D. program here. He had kind of a pretty neat pathway because his Ph.D. advisor at the time, Neil Kay, moved. And so he actually completed a lot of his research training in San Diego and then came back to finish medical school, but did a really elegant work with Neil Kay and Tom Kipps in chronic lymphocytic leukemia. Erik went on to do AP only at Stanford with a subsequent hematopathology fellowship, postdoc with Irv Weissman, and came to the University of Wisconsin where he's been extraordinarily successful. So Erik's been there 11 years, and in 2007 he became residency program director. He's vice chair for clinical education. He was recently promoted to full professor, so done very well. And so we were interested in inviting Erik not only because he's a hematopathologist, but more because he created, in conjunction with his colleagues, an innovative program to teach clinical pathology, which he published on, and so he's going to talk a little bit about that. And I think that the two things I want to communicate to the trainees is that Erik's a good example of, here's someone that didn't do any CP training, but he was put into a position where, like all of us, you train for one thing, but when you start your job, you may be presented with an obstacle or a task that you weren't specifically trained for, but you can always use the tools and resources around you to develop something. And I think we look forward to hearing this talk entitled An Experiment with Clinical Pathology Education.
Thank you, Mike. So it's a pleasure. Thanks a lot for the invitation to Mike and the department. It's of course a pleasure to come back here because I grew up here and did, at least as Mike said, most of my MD PhD at this institution. When I started as MD PhD, Dr. Furt was the director of the program, and so have known him for a long time. And I was reflecting with some horror this morning that the last time I actually spoke at this institution was almost exactly 20 years ago when I defended my thesis. So, which went okay, so it should be all right. So I'll do the usual disclosures. Of course, I have none because I'm an academic pathologist. And the other disclosure I want to make is, as Mike mentioned, I'm not even CP boarded or trained, so I have no business talking about this at all. And I guess my other disclosure is that I've never really given a talk like this. I've talked about lots of science things and lots of medical knowledge things to students, but I've never really talked about sort of education policy or told a story. I do have data, such as it is, but as Mike mentioned, this sort of program has been published, but this is really more of a story about like seeing a problem at the University of Wisconsin that I think is a bit more global than that, trying to come up with some solutions. So you'll have to bear with me as I sort of struggle through how to describe that to an audience of smart folks, and hopefully we can have a discussion about this, and I'd love to hear how you guys are dealing with this problem, and whether you think I'm full of crap. So, because I'm inevitably I'll offend somebody because I'm saying that there's a real problem with CP education. So what are the problems with CP education? There have been a few publications about this topic, although not many, considering every time I go to the APC program directors meeting with Leo, I hear everyone grousing and complaining and nodding appreciatively when say, well, I don't know how to teach chemistry, I don't know, how are we doing the stupid milestones? But no one really sort of tries to investigate this and publish it. But here's one example of one such group that did, and they identified a number of challenges that you can almost think of just in a common sense fashion. First off, if you just think of clinical pathology in general, it's such a huge and varied enterprise, going from hiring and firing a technologist to understanding how exactly you do a free calcium measurement versus a bound calcium measurement. And even if you just think of chemistry by itself, you're talking about 300 some different tests. So if the resident does what most residents in this country do, about 3 months of chemistry, they're exposed to all these different tests, and it's unclear to them, I think, am I supposed to understand how to do every single one of these tests, or am I supposed to understand some broader perspective, or what? This is sort of, I think, amplified by the fact that when they see faculty members doing what I guess we could say are anatomic pathology consultations, apart from perhaps autopsy, those generate money. And so they're appreciated by department chairs and hospital administrators, et cetera. Whereas very often the consultations that occur in clinical pathology are sort of on the phone, and they are very helpful to your colleagues. Your colleagues may be very pleased with you, but they often are not billed or billable services. I know even in HemePath, it's more work of my time to make an interpretation of a smear billable or billed than it is just to do it and tell them the answer. Certainly in that setting where you have residents sort of acting as some kind of go-between between faculty, people calling in from the outside, and technologists, I'm sure you've all experienced this. Residents often get bypassed. One, because the person doing the bypassing thinks they're not going to know the answer anyway, and they're going to end up calling the faculty anyway. So they just like, and I'm busy. I don't have time to have this little chat with resident PGY1, so I'm just going to go right past. And that's kind of compounded by the fact that, at least in many places, it's very difficult to have a resident always available to cover a certain CP service, especially if you have multiple sites, as you guys do, especially if you have a smaller program, and if you have an off-site lab where, okay, if you want the resident there on the spot to be the consultant, well, does that mean they take a bus to some distant place and sit there all day and while the rest of their colleagues are doing pathology training? So those become difficult. I'm actually going to, I'll come back to this a little bit, but at least at UW, I think the situation may be a little different here, but at least at UW, we have very limited numbers of faculty in CP. For example, we have one microbiologist, one, and just recently last week, now 2 chemists. You know, so if that person is responsible for all the microbiology education, it's a little difficult to say, here, you have a resident, they're just going to hang out with you all day long while you're doing emails and making up new protocols and trying to do your research and being on a committee meeting. And so I think that, the faculty, unlike in, let's say, surgical pathology, where essentially you need a faculty to put their eyes on that slide at some point anyway. So it sort of fits well with residents sitting there with you and looking at the slide with you. Whereas in CP, the faculty numbers are much more limited. And it brings up a second question of, if the faculty are limited and so therefore they say, oh, you're going to go learn today something about coagulation, go sit with the technologist at the bench and do this test. Now that's fine for 20 minutes, but what you end up with is 8 hours of the resident sort of standing there, watching some guy pipette pee into a machine and And the technologists may be very skilled and very knowledgeable, but what are they teaching? They're going to teach the resident their job because that's what they're good at. They're unlikely to teach the resident the director's job because they don't do that job. They may know a lot about consultation, they may know how to answer questions, but the question of whether you're teaching them a pathologist's job or a technologist's job, I think, is an issue in CP. And lastly, or not lastly, it's just one of them, could be a much longer list. At least most of the residents that I've come across walk into residency and they believe that they need to learn surgical pathology because that's what they're going to that's really what their job is going to be when they go to Methodist or Hennepin County or wherever. And so that's what they're here to do, and CP is just sort of this thing, I have to do it, and I know, because to get a private practice job, I know I got to do that, but I don't really know why. And I'll tell a little story about my own decision making about AP-CP, which definitely colors my view of this. And so when I was looking at residency programs, as it turned out, my wife had taken a fellowship in San Francisco. And as many of you know, fellowships are decided before residencies are decided, so then I was sort of stuck. It was horrible. I was stuck having to go to San Francisco. And so in San Francisco, the residency programs, it's Stanford and UCSF. And it's hard to believe, even now, because it was less than 20 years ago, but Stanford did not have a CP training program at all. 0 CP residents, 0 CP training. So at Stanford, you did AP only, and then almost everybody, if you could walk and chew gum, you got to do the surgical pathology fellowship, and then off you went. And Whereas at UCSF, many residents did CP only, and only some did AP, and very, very few did both. So I was sort of, being a clueless student, I sort of was wondering which one I should do. I knew I wanted to do academia, so I knew I didn't want to do both, but I was really sort of on the fence between the two. And so I went and interviewed at both places, and this is obviously a different time. Like, I wouldn't recommend interviewing only at Stanford and UCSF these days, but I was an MD PhD graduate from this program, and so, you know, I could go anywhere I wanted. And so I interviewed, and then I went back for a second visit, mostly to talk about sort of research possibilities, and I was still sort of up in the air. And then I had lunch with the chief resident of clinical pathology at UCSF, and he was doing this really great research in HIV in the lymph node, and had papers as a resident, and a good guy, nice guy. Having lunch with him, and he's like, you know, really, like, CP residency, it's just like bullshit. Like, you don't do anything. You just have to spend your time and then get your boards, and then you can go, you know, run the flow lab or something. And then on call, you know, you just say no all the time. And I was like, so I thought, like, well, like, if I'm going to spend, you know, 2 or 3 years doing this, I'd like to actually learn something, you know, not just sort of like stand around in the lab. And so that kind of convinced me, and I'm sure that there will be people in the room who say, like, that's not at all what CP education is. Are you kidding? But at least that was the impression of the chief resident at UCSF at the time, which was, I think, was thought to be one of the better CP programs. All right, so with that background, so anyway, so I did AP and then HemePath. So back to the problems of CP education. So one of the problems, at least in the literature identified, was what I have here. So in a CAP survey, they asked recent graduates, do you think your CP training prepared you for boards? And then they could say yes, very much, or sort of, or no, or not, definitely not. And a majority said very much, or for the most part. But then they said, what about, did they prepare you for practice? And you can see only 12% thought that it very much prepared them for practice, and 32%, so the minority didn't think it prepared them for practice. Whereas if you ask them about their AP training, and presumably mostly this is surge path probably, the majority said very much my training prepared me for practice, which reflects probably their bias coming in and the bias of their program directors. So the question is, are we preparing for boards or practice? And this, to me, this reflects my own, if I survey my graduates, I haven't done it for a couple years, but when I've done it and say, you know, what do we do well for you, what do we do poorly for you, basically all of them, especially those in private practice, say, I got here the first day and they said, you're director of the microlab. And I said, what? Is there a manager I can talk to? Because they felt very unprepared to order a new piece of equipment, to decide to bring a test online or not, to hire and fire somebody, to set a budget, to do any of those managerial things that we all are supposed to be training these kids to do. And so my own graduates, I've identified that as a problem. Now, if you turn that around and say to the current residents, hey, how'd you like some more lectures about management? No, no. I need to learn how to diagnose breast cancer and leukemia, and I can't. This is boring. I don't get it. So it's hard to convince the current residents that they need to know it, but then the graduates all come and say, I don't know what to do. I'm calling my former chemistry advisor or mentor to understand how to practice. All right. So in terms of CP at UW, when I became residency program director, this is what it looked like, and it had looked like this for years, and it looked like this for the first few years that I was program director. And this looks very similar to, if you look on anybody's website, this is kind of this thing you'd see, where we did not do year by year. Some places do a year of anatomic pathology, a year of clinical pathology. We intermingled the rotations with pretty heavy in AP in the first year, as the way we used to do it. And over the course of a 4-year residency, it had become 4 years by the time I was program director, they did 3 months of chem, 3 months of what we did is combined immunology and coagulation, 3 months of micro, 3 months of blood bank, 3 months of HemePath at UW, which for our HemePath, it's just integrated. It's all the tissues, basically anything with a lymphocyte in it, flow, peripheral blood, body fluids, all those things that you think of HemePath. So for the purposes of the board, I call HemePath at UW CP rotation, although it's truly both. And then they also had 3 months at an outside hospital, which was largely heme path and very autonomous. So that was my, I guess actually 19 months of CP. And a couple other sort of just factoids about it. So for example, blood bank, we gave the first year residents 2 months of blood bank with the idea of preparing them to be able to take call, because many of the calls were blood bank related, as you know. And then they do a month, usually either in their third or fourth year. Micro is a little more sort of pushed towards the early part of the year. And the organization of these rotations was variable. Microbiology, for example, was very organized. And Dr. Carol Spiegel, who was our microbiologist for many years and co-program director at one point, had this very rote curriculum. They went through this, they took this exam, they went to the bench, this bench for a week, this bench for a week, this bench for a week, this bench for a week. They did unknowns. And so I think the residents, on the one hand, she drove them nuts. But on the other hand, they came away saying, oh, you know, I got a sense of what I was supposed to learn, and I think I kind of learned it. My argument with Carol was that they're spending 90% of their time learning what the text job is, as opposed to learning what your job is. But that was an argument that was only resolved when she retired. So I guess I won.
And to be fair, the micro that's covered on boards is kind of what the text job is.
Exactly right. Oh, so you bring up an excellent point. So right, so back to the, did we prepare you for boards, or did we prepare you to practice? Right, and they take a RISE exam and they say, well, how was I supposed to know that blah, blah, blah was coagulates negative? And see, I don't know ACP, so I'm just making shit up. Right, and the same is true, and you know, back to the chemistry example, like, you say, well, that's ridiculous. You can't learn the factoids about 300 different tests, but that's what's tested, because some chemist is like, oh, this is a great idea to ask about, you know, which electrode do you use for potassium? And
but that's a problem with boards.
that's a problem with boards.
Yeah.
And as John certainly knows, there's always this inherent conflict for the program director who says, well, I got to have my kids pass boards, because that's sort of key. And the residents are very nervous about it. And if your residents come back with an in-service exam score of 20th percentile, then other people start getting nervous about what you're doing. But you're not really training them to do the job. So, agreed.
But in the current era, permit me to say one more
Absolutely.
comment about, in microbiology, the technologies have increased so tremendously, and they blend into molecular diagnostics, immunology, et cetera, with choices of instruments. So I feel that the current residents have an opportunity to learn a lot more about all the advances and how you apply certain technologies, how you make decisions. And so I think it's quite different than the era when Carol was head of the lab there.
I totally agree, and there's no question that, so our current microbiology head is Kurt Reed, and even since he came, I mean, immediately he was like, what are you guys doing here? Come on. So we're doing 16S RNA sequencing, and now we're going to do mass spec, and there were opportunities there that I think, to be honest, were missed in a way, and this is a recurring problem of, oh, got it. You know, if 3 residents had been able to be involved in bringing on 16S RNA sequencing or the mass spec instrument, like that would have been a great experience for them. But of course, you can say that, but then, so how long were they supposed to be on micro to be able to do that? A year? So that's again a challenge, and it's going to come back to the end with the milestones where, you know, one of the milestones, for those of you who don't know, the milestones, you probably mostly do, right? How about, if you don't know what milestones are, raise your hand. Oh, good. Okay. Well, so well, you are blessed. So you lived a blessed life. So the ACGME, the thing that accredits all, has moved to a sensibly enough. Like, let's judge the residents' abilities on basing on what they can do, not sort of what we think we taught them. And so, for example, that might be, can this person gross a complex colectomy specimen and get the lymph nodes out? Yes or no? Can they do it really well all the time or not all the time and they get a 1 through 5 score? And this started in July. You'll all be suffering through these evaluations for the next 100 years. But in CP, one of the milestones is essentially buying a new piece of equipment. Well, Okay. But I think we could all agree that it'd be great if the resident could go out and do that and have that skill set. But in the context of a real rotation, whether it be a month, 2 months, 3 months, or 10 months, how many residents are going to get that opportunity to really delve into that question or not? So that will come up. That'll come back. All right. So that's where we started. So what were the results of doing things that way? They weren't terrible. Almost all the residents passed boards. It was a very rare person who would fail. And I would at least argue that since I've been program director and been sort of privy to what the reasonings might be, the kids who have failed since I've been director, there was all sort of, one was dyslexic but didn't want to admit it, so didn't take the extra time that she could have had. And then she immediately passed the next time. So the boards were fine. One of the problems with the boards is they don't come back and tell you much about what your residents did. They just tell you your residents on a whole, on average over the last, I think, 5 or 7 years, they're in this tercile. So that doesn't really give you much information. And as it turns out, being good Midwesterners and committed to mediocrity as we are, all of my residents are in the middle tercile of everything. So we're all like slightly above average, I guess, even though we're in Wisconsin. And for those of you who don't know what the RISE is, so the RISE is an in-service exam that the ASCP creates. It has its issues. But it does, a lot of people use it every year and require their residents to take it. Do you require your residents to take it? So we require the residents to take it. We don't use it as a promotions sort of cut, but we do use it to tell the residents, well, you don't seem to know much about this topic. Or you're doing great. Don't worry about it. You're fine. You'll be fine for boards. And the RISE exam is helpful in the sense that it is predictive of board success. So if you're above 50th percentile in the RISE residents, you will not fail boards. I mean, unless you just shoot yourself in the head that morning, you'll be fine. If you're 25th to 50th, you will be unlikely to fail boards, although it could happen. And then if you're below 25th, it's about a 50-50 proposition. So, and the other nice thing about the RISE exam is that they do give you back feedback in specific areas: chemistry, micro, blood bank, surgical pathology, cytopathology, hematopathology. And actually will give you not the questions that were given, but at least the topics. And your residents all got this thing wrong. So I know I can go tell them, I've told you before, but PCR, TCR gamma does clonality for all T-cell lymphomas, not just gamma delta. And that sort of, you can give that sort of feedback. So our residents were doing this. So on average, this is national percentile on the bottom. So if you take all my residents 1st through 4th years and look at their AP, in other words, forensics, SurgPath, and cytopathology, versus CP, which is sort of everything else, and I'll say that HemePath is included in that, although one could ask whether that's appropriate, but anyway, and you put them together, my residents were on average at the 75th percentile compared to all residents in the country, which I guess is good, but in CP they were about 10 points lower. The other thing was this, so there's a lot of variability. And in particular, yes, there was variability between residents, but there was also variability within a resident. So if I look at a random, this scale is just arbitrary, a random resident, what I would see is that their SurgPath's actual score, which of course tracks with percentage, but their actual score on the test would go up, every year in some reasonable slope. And generally speaking, I would say residents tend to, if you're a 90th percentile on something as a first year, you tend to kind of end up there as a 4th year in general. So my little hint, if you're really excited about having residents get 95th percentile on RISE, just only take kids who get 260 on boards. They may be jerks, they may know nothing about pathology, but they'll do well, so it'll be fine. So our residents would seem to be learning something. And in CP, they were just all over the map. So if they had recently had the rotation, they probably did a little better. If they hadn't had it for 2 years, they didn't know anything. And so they'd jump all over the place, and you really couldn't get a handle on, well, is there something specifically wrong here or not? If you ask how they felt about the rotation, so the ACGME has been doing annual surveys of residents, which are anonymous, so they can be honest. Whether they always are or not is questionable. If you look at the surgery specialties results, they always, 100% of the residents think it's fantastic and they never do duty hours violations. So clearly someone's like got the electrodes attached in there. But take it for what it is, but and CGME asks them a bunch of questions, but they also say, what do you think about your education in these areas? And they ask more than this actually, but I'm just doing these because these are sort of the typical CP/AP things. And you can see like this is sort of before we made this change in CP, and you can see that they, generally speaking, it wasn't terrible. They were a little lower. And my own internal annual survey, the same thing. They were a little lower, but not horrible. And I'll mention that my red line there is, so when I'm talking about CP from now on, I'm putting HemePath in AP because our HemePath service really functions like a kind of a surgical pathology service, like here's your cases for the day. So it's a little, so we didn't really include it in this reform except for in a small way. And subjectively, what was happening, not subjectively, but what sort of subtle things happened? Well, one, these CP rotations, the chief residents very quickly learned that if they wanted to be a favorite of their peers, that they would put CP rotations right after hard things, or things that had carryover, like autopsy, or surge path, because the residents were going to sleep for a month after they'd been on surge path, or they were going to spend the whole time doing autopsy reports. And I'll say that when I became program director, autopsy was like, that was 80% of my complaints, believe it or not. It wasn't surge path, it was like, oh, there's so much work on autopsy, blah, 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 blah. That we've fixed, but they use that time to sort of catch up and enjoy Dr. Solomon's 3 to 4 hour brain cutting sessions, which kind of ate into the day when you were doing other rotations. So the other thing they did was we have very few fellows at Wisconsin, and our residents do almost all the tumor boards, of which there are many and are proliferating. And so the ones that everyone knew took a lot of time and had a lot of cases, those would be given to people rotating on CP rotations. So again, now they're spending 3-4 hours taking pictures of breast calcifications, and then they're spending an hour and a half at the meeting during the day on a rotation. So they're sort of never around. In addition, I would say when I became program director that we didn't have nearly enough PA help in the gross room, and so if it got busy, frequently there'd be senior faculty sort of wandering about. Oh, Jimmy, can you come up? We need some help in the gross room, and so off they would go. So understandably, this tells the residents what we value, right? And it tells the faculty what we value, and the faculty were not very happy. And there was this real kind of like pissy kind of relationship between AP and CP faculty, which was unfortunate. And then I'd have faculty tell me, well, this resident, she's a 4th year, she's on my blood bank rotation, she knows less than the med student. And I was like, really? That 4th year who I'm talking about is now faculty at Mayo. We get like 95th percentile on every rising topic. And what are you talking about? But but the fact is that 4th year had 2 months of blood bank as a 1st year. Now 3 years later, okay, she'd had the occasional call about someone had a rash, but she didn't really do much transfusion. Now she shows up and yeah, she didn't remember Cal and Lutheran and all those things. I'm sure she studied them for boards and did fantastic, smart woman. But I got this. Well, your residents basically, and this was a former faculty member who's now a chair at a place I won't name, who was a little blunt. And he's like, your residents are idiots. Like, who are you taking here? And then the other outcome was I had not a single resident for many years go into any CP specialty except for HemePath. No one wanted to do transfusion medicine unless they didn't get a job, and they would do transfusion medicine fellowship. Certainly no one was doing chem or micro or anything like that, or molecular for that matter. So the real tipping point though is I was talking to an outside faculty member at a private hospital who was a resident in our program in the 1990s, and I sent him this data about, oh, your rotation, here's your results for your rotations. People like it, it's doing well. And he's like, oh, I see chemistry did really badly. And I said, yeah. And he said, oh, that sucked when I was a resident too. And I thought, like, okay, it's 20 years ago or 15 years ago, and everyone's, oh yeah, it just sucks. Well, let's do something about it. So the problem we were trying to solve. CP rotations, to me, this is not just a UW problem, I would posit. A lot of it was, welcome to this rotation, here's a book, go in the corner and read. I'll see you in a month. Because you need to know stuff for boards, right? So you got to read this book and memorize stuff out of it. And 2, what we're teaching you is to go do the text job. So go stand there and watch them pipette. And you're uncomfortable, The tech is uncomfortable because they're trying to get work done and they're not sure what to say to you, resident. And what am I supposed to be telling you? I'm just trying to do my job here. And I guess I would say, I'll admit that at UW Hospital, I think, and this I hope is not a problem here, but that the hospital is very worried about dollars and cents, and they're not so much worried about the education mission. And so when I say, hey, why aren't the techs teaching the residents? Well, we don't have FTE for that. They're doing the job. They're not here to teach residents. And in fact, the only reason I got them to do anything is because we actually had a clinical lab medicine, clinical lab scientist undergrad program at UW, which in the wisdom of the med school is now shut down. But we had it, so therefore there were FTEs in place to teach those tech students, and therefore they kind of could teach the residents. Again, teaching them what job? Well, the same job they're teaching the tech students. So some of the UW specific things I've already mentioned. Faculty were a little low. Big surprise, the faculty had variable commitment to resident education. Some were great and some were not. And as Don Rumsfeld said, you go to war with the army you have, not the army that you wish you had. And I would say I go to CP education with the faculty I had, and not those that I wish I had necessarily. And I wasn't hiring and firing any faculty, even though on the CGME website it says I should. Or should determine if they can talk to the residents. Well, I have one microbiologist, so I guess, I can decide. So the result was, as I just went through in detail, that the evaluations and the scores were lower. Okay. So I wanted to do the following things. I wanted to improve the retention of material, so I did not want fourth-year residents showing up in blood bank and not learning this than the medical student. I wanted them to do more pathology-level activities and repeatedly do these things over time. It would be nice if I'm going to ask the faculty to do more work or more teaching or more time with the residents to try to sort of, at the same time, make it a bargain for them. So an example would be we have a great molecular biology guy, Bill Rayrauer, who was like super dedicated to teaching. And he'd have the residents for these 2-week little blocks, and he'd go through didactics, and he would show himself at the bench, and he would hours and hours, and then 2 weeks later he'd do it all over again with another resident. I mean, this was not every 2 weeks for the whole year, but it was, he'd just do the same thing over again with one person. I'm like, well, why are you doing that? You should have him do it once with 4, so they can interact, but he's not repeating himself. And then hopefully this would result in improved scores and outcomes, maybe even improve recruiting to the program if we could sort of say, hey, we're doing this thing differently, this thing that you think you just sort of have to do for private practice. And so here's what we did. We created a thing I called CP Superblock. And so what we did is we took residents on blood bank, micro, coag, immunology, molecular diagnostics, cytogenetics, and chemistry, and excluded heme path for the reasons I described. And we just said, okay, we're going to take 4 or 5 of you, ranging in PGY 1 to 4, in a team. You're going to be on for 3 straight months together. So let's say July, September, October. Or we could do July, August, September, that's the way the calendar works. And then August we take off because we're French, So July, August, September, and you're all together, and then and you're going to do one of these blocks every year of your residency. So you do 4 of them, and so the actual time spent in these things were not really changed in terms of total months dedicated to it, but in a sense, rather than having 3 months of micro, you now had 12 months of micro, but hopefully high sort of impact learning opportunity things, not standing around or golfing or whatever it was they were doing. And so I also said to surgical pathology, like, you deal with your own problems. You are not taking residents to do grossing. I don't care how busy it is. And get some PAs. And I argued and rather vociferously with the hospital, and then they ended up doing that. And then in part, we still had you're always going to have the problem of autopsy kind of trickling over in the next rotation, but in a way we decreased it because now we put the residents in a 3-month chunk, so you couldn't sort of intersperse autopsy in between the different months. So those things I think were addressed. And so what we did then is not just create a cloud of residents that sort of randomly roved around, but we said every week you're going to be primarily responsible for this area. Blood bank, micro and chem were sort of combined, and then immuno, because they had to do a fair amount of work preparing clinical histories and stuff for the gels to sign out. So that was a separate resident. And then generally there were one or two that were assigned to really nothing. So the benefit of this was if people were on vacation, and you see right away Bartosz takes vacation the first week. This is when Bartosz was the first year. And so you could do vacations, and you still have coverage of these things. So there was always residents available on the service, and the techs or faculty wouldn't get the person's not available, they're not here, whatever it was. And then and they would rotate those every week, and then they would also do. We have didactic conference every morning at 8, and on Thursday that's dedicated to a sort of a CP case presentation format where the residents present. And so these residents on this rotation will be the ones presenting, along with the HEMPATH resident. And then they had journal club. So they got assigned in this way, sort of in my little colorful Excel sheet. And this is what their week kind of looked like. And I apologize if it's a bit small for you to see. But generally what we try to do is that, so the things that say all on them, ALL, would be that all the residents on CB Superblock would be going to that thing. The things that just say, for example, the green bars at noontime on Wednesday, it was only required that the immunology assigned resident show up to do the gel sign out. But for example, so in the area of immunology, they would all come and do a session with Alan Bridges, a rheumatologist who does our gels in our lab and runs kind of the ANAs and those sorts of tests. So he would either do a didactic with them, or he would look at ANAs in the scope with them and explain, what's a speckled pattern and what's this and what's that. And he's a busy guy. He's the chief medical officer at the VA. He's a practicing rheumatologist. He does science, and he says to me, I like this so much better because even though I have to do about 6 of these sessions in the 12-week block every other week, I'd much rather do that with 3 or 4 residents than give 4 or 5 lectures to your didactic session with 20 residents, half of whom are sleeping, a third of which are on their phones, and they don't know what I'm talking about, and there's no interaction. So he, even though he was spending way more face time with residents than typical, perceived it to be better, perceived his life to be better, perceived his teaching to be better. And I think the same is true for some of the other faculty. The one hematology thing we did was on Monday morning, because of course on the weekend the techs are not as specialized in moving heme, so there's a lot more sort of, I don't know what this is, can you help me with this smear or this body fluid? So we would have the CP residents sort of look at those and kind of try to sign those out themselves, and then sit with the HEMPATH faculty and sign those out. So the point was to spend time doing faculty level stuff, and if that's signing out molecular tests, if that was interacting with the ID team in what Carol used to call plate rounds, in the micro lab, if that was all getting together in the blood bank and being shown how to do a technique or a test. So I think we made better use of the text time, better use of the faculty time, and hopefully spent more time talking about upper level things. You might notice the little lonely chemistry time on Friday afternoon with sleepy residents. Chemistry, I think, could have worked really well in this system and kind of didn't, for maybe some reasons we'll talk about and things that I think we're fixing now. So for many things, this worked really well. And for a couple things, it did not. And we'll talk about what those were. So,
Are you going to get to the issue of taking call? Did residents take call on this rotation, and so how did that work? Did they get their all CP call or by special call?
sure. So our residents do. Well, now the first years don't do call because they'll cry and stuff. So so they don't do call anymore. Just you couldn't deal with the supervision problems. And so our residents take call for everything together for a week at a time, except autopsy. The residents on autopsy cover autopsy call, which is really a weekend thing. But otherwise, so they do, and we do tons of transplants like you guys do, so they get a lot of frozens for transplants, but they cover everything. So during the day, these residents were dealing with problems, basically till 5 or 7 o'clock, and then it was off to the call resident. All right. So as I said, faculty seemed to be a little bit happier. At least most of them were happier. I was not particularly happier because I ended up being in charge of this thing, sort of, and like scheduling things and listening to complaints about this and that and switching people around. So that wasn't so great. I asked the residents a year later, so now I had a bunch of residents who had done the old way and the new way, and I asked them, which one do you like? And you can see most of them either strongly favored or favored the new system, and only one liked it better the opposite way. Now, that could be that they just felt like, well, you know, it's got to be better because it's different. Or we kind of like Ranheim, so we'll just say, you know, he seems to think this is a good idea, so we'll just pretend we like it. And then, so let's see if, you know, is that grass actually greener? As it turns out, it is actually, because if you look from the side, it looks greener than if you look straight down. Just a fact. So let's see what they say to CGME. So you can see this is over now sort of 5 years, and where we implemented the thing, and you can see that there's a little nice Hawthorne effect there. So the residents found out that I was going to try to fix this, and they heard me yelling and screaming at the faculty, and so they suddenly believed that CP was better at UW, even though nothing had changed. So it was interesting. But then, as you can see, in general, the CP rotation scores and feelings from the residents improved. You can see chemistry is an exception. And some, like micro, is sort of flat. But a lot of them, like blood bank, which we'll talk about in a second, really improved a great deal. This is not because I suddenly gave better wine at the barbecue or increased their book fund, because now they're pissy about Surge Path. So they're not just happier, they're happier about CP. Surge Path is a whole other issue. That was sort of a perfect storm of badness there. But how did they do? Did they learn something? So I already showed you the graph with the blue bars. So average scores before we did it, average scores after, same amount of time on both sides. And you can see that the CP average scores on the RISE exam anyway increased, and essentially we're now equivalent to the AP scores, and the AP scores didn't really change much. This is by year, and you can see the CP scores improve and kind of meet the AP scores and sort of go along. Now, as I say, the RISE exam is a little bit of a false, I will say that if you look at the entering board scores across this time, they did not really change for our residents. So we weren't taking better test takers or worse test takers, I don't think. But nonetheless, CP improved. Okay, so that's good. Individual categories. So the one that really stands, or one of them that really stands out, is blood bank. So now I could take full credit for this, but I'm not going to, because I'm going to give credit to Nick. So Nick Rosa was a junior faculty who came right when we started doing this. And he was coming from a system at Iowa, which was very much classical. You know, you do blood bank, and he did his fellowship there. But he said he was a good sport about it, and said, okay, I can work in this system. And so all of a sudden, we had a faculty member, which was a change, who wanted to teach didactics, who wanted to do sessions with the residents, who took this framework and said, oh great, I'm going to do all these things with the residents when I'm on service. And I'm telling you, when he wasn't on service, things declined precipitously. But nonetheless, he was on enough, about half the time, that the residents would tell me, oh, Nick's doing this exactly what the CP Superblock should be. He's taking advantage, and we're signing out antibody reports, we're writing antibody reports, we never did that before. We're not spending all our time doing fake physicals on apheresis patients. We're really doing sort of pathology level stuff. So that was great. And you can see that their knowledge improved. And for the first time ever, I will say, I have had not one, but I think 3 residents who say, oh, I'm interested in transfusion medicine. I've never heard anybody say that. And all you have to do is have someone who does it well and is enthusiastic, right? So the other things that did well were lab admin, and I think some of that was just a little more exposure to true administrative duties. The clinical lab director did a lot of sessions with the residents, did some case studies with them, did the things that you need to know for boards, these silly things that no one ever remembers ever again, but she went through some of these things with them, and so they improved. And the other thing was kind of these generic things. Special topics and heme special topics are kind of, to be simple about it, molecular. Heme has coag in it, but special topics is mostly molecular, and Bill Rayrar had more time and repeated time with the residents, not 2 weeks just somewhere back in distant memory. And so he was able to, I think, just let everybody come up to speed, because of course we start with first years. One of them got their Ph.D. in molecular biology, and one of them's never even, they can't remember the different base pairs, right? So they help each other, and they get up to speed, and then they get repeated exposure. And I think something I didn't really emphasize before, but I'll emphasize now. Why do my residents feel comfortable diagnosing DCIS in the breast when they're fourth years? Because they've seen it a bunch of times, and they've seen it, relatively speaking, about every 3 months on average over their entire residency program. They've done SurgePath. And so they feel, eventually they remember it. I mean, initially they look at it and they go, oh my God, I'll never understand this topic. It's too huge. I don't do any of this in med school. But eventually they do, whereas that was not really true in CP. Interestingly, and here's a credit to Carol, Kurt Reed's perspective or way of approaching this is much different than Carol's. It's much less formalized and curriculized, and he would be the first to say that CP Superblock, this does not work for me. I just want like a minion sort of, I'm just going to dump knowledge on them all day long, and we're going to talk to clinicians, and I'm going to do this stuff. And he's good at it, and the residents at Northwestern when he was there really liked him. But you can see that so knowledge in micro, if anything, slipped a bit because they weren't doing this sort of very formalized thing. All right, so other data, again, boards are kind of a dumb metric because if you start with everybody passing, it doesn't really help you. But I'll say at least it didn't get worse. So everybody passed boards since we did this in CP. So I guess the things that I maybe didn't point out, one, the residents like being with other residents, big surprise. They kind of like teaching each other. The first years feel much more comfortable because when they get asked to fill out this slip about, well, so-and-so wants to do a non-clean catch urine specimen for such and such, they don't know what to say. But they have a third or fourth year says, oh, no, here, you say, this is what you do. And so I think there was a lot more resident teaching. The research output by residents actually very much improved. Now this may have nothing to do with CP Superblock, although I would argue that it probably does. I think they got some time to be able to sort of follow up a project. Now, I would also say our residents have switched from about 85%, 90% of private practice 6 years ago to now it's about 50-50 in our program. So that's part of it's just motivation, but nonetheless. I think this did provide a platform for performing quality improvement projects, which in the milestones is they love quality improvement projects. And so that's a nice thing because John and I have to go and say, like, yes, all of our residents are doing quality improvement, really. And they often are, they just don't realize it. But here they were really doing real projects. So for example, the first year we implemented this, one of the senior residents took on the task of, we're going to switch C. diff from an immunological test to a molecular test. And she did sort of everything. I mean, she talked to the clinicians, she talked to the hospital, she explained, she figured out how much the machine was going to cost, what the per test cost was going to be, and ended up with a publishable, posterable little project that actually really did a real thing. And I would argue that when she went and got her job in Kansas, that she could say, at a major U.S. teaching hospital, I implemented this big change in microbiology that's important. What didn't work so well? Graduated responsibility from PG 1 to 4 was in some ways inherent, and as I just said, the fourth years could be helping the first years, but I didn't really have a really good way of formally sort of saying, you're doing this as a first year, this is a second year, this is a third, apart from the first and second years did a lot more bench things, and the third and fourth years were expected to do more sort of quality improvement things. But that's a real difference in graded responsibility or teaching, I suppose. But it wasn't really clear, and I often sort of wondered, like, I saw Bartosz as a first year taking this, and I thought, oh, this is great, this is good for him. But is he going to do the same exact thing as a fourth year? Or he's going to be like, this is not great. I wanted to require QI projects, but then it ended up, well, who was going to enforce that or monitor that? And it turned out it was me. And I just couldn't do it. I just could not, sort of keep each one of them like, well, what did you do? You got to present it. And so that kind of crumbled over time. And some residents still did it and some just didn't. The fact that they had all these scheduled activities during the week did result in complaints about, well, I called the resident to see this interesting test we only do once a month, but then they said, oh, they're signing out gels, or they're doing this, and they can't leave. So there was a little bit of, the residents knew what they were supposed to be doing, but some of the other players, faculty, technologists, me, whoever, didn't always remember that they were supposed to be somewhere else, and then were sort of angry that they didn't show up to do my thing right then. And in micro, for example, Kurt Reed said, well, I'm trying to get the residents to come in the lab and see what these techs are doing, but they tell me, well, I can't do it at 8, I can't do it at 9, I can't do it at 10 because I have these things. And I want my resident here to learn this stuff, which leads into faculty. So you may be surprised to learn that changing the system does not change faculty personalities or teaching interest or ability. And over this time of the 4 years that we sort of had this truly in place, I got a different microbiology director, a new transfusion medicine doc, and so some of the faculty who were really engaged with the residents had changed, and they started sort of pushing, like, can we go back? Can we have our own rotation? Can we have our own rotation? Until finally this last year, of course, the inevitable revolution against the authority, and I'm not sure I felt the love so much, but they said no, and then we got this year we actually we had recruited a new transfusion medicine director, Tom Rafe from Iowa, and he and Nick Rose both were like, no, we need the resident. I said, well, why do you need the resident? Like, well, my residents say, you guys are doing the perfect job in this specialty of teaching. What do you want them for? And they said, well, we feel like right now they're doing 20% of the pathologist level things, and they could be doing 80. And we want to change the whole culture, and we want to make the techs call them first, and we want them to be consultants. I said, that sounds great, because that wasn't the case before. So promise me you're going to do that and not just make them do physicals and write fake notes. And they said yes. So anyway, so now this year, starting in July, we took this thing that I came to tell you is so lovely and kind of dismantled it halfway. So what we did was, blood bank and micro, and this is totally the faculty saying, I want it this way, and I'm not going to play in your sandbox anymore if you keep making me do it this way. So it's fine. I mean, I'm going to expect them to deliver. But so blood bank and micro are back again as standalone rotations. Blood bank is always covered by a resident, and they assure me that they're going to do a lot of experiential learning. Micro is different because Kurt Reed's the only game in town. If he's off collecting birds in Colorado for his research, there's no sense having a resident sitting there because there's no one there who really knows what they're doing. So sometimes he has a resident, sometimes he doesn't. And then the remainder, the people who wanted to keep the Superblock, all those listed there, are staying together. So the benefits to them, I'm hoping, will remain. It's fewer residents on together at the same time, and it's only for 2 months instead of 3. So there's a little bit of a crunching of their time to sort of spread out their knowledge, but not to deal with that. And then some of the cytogenetic stuff we moved to HemePath. It kind of fits better in HemePath anyway. And I was getting grief that your residents have 6 months of HemePath. I said, yes, but they love it. So I'm a HemePath. So this is what the rotation. So they still have there still is this white space. And in the white space, they are both supposed to be doing QI projects. They're supposed to be doing, they have these essentially modules that Terry Darcy has, and others have created where they're supposed to be going into the lab, interacting with the technologists, asking questions, dealing with clinical consultations, and then they have these sort of fixed, didactic-y / faculty level sign-out things. And Terry reinstituted what we had done a while back, which was kind of going around the lab in a group and looking at sort of interesting problems that came up today or last night. We had implemented that way back when, before I did all this stuff, and it was great for like 6 months, and then half the faculty stopped going, and then 75% of the faculty stopped going, and then it turned out to be an hour listening to 2 chemists talk about their golf game. So, I mean, it's cool if you like golf, but otherwise the residents were not really learning much. Okay, so just sort of as a bookkeeping thing, so this is what we're back to. For those of you who don't know, you need 18 months of CP to take your boards. And so there's my 18, and then they have lots of elective time to do other things, and many of them do flow and molecular as electives in addition to what they have to do. And so I'm not going to read the slide for you, but I think what we need now, what I really need to do with this is how do we, if we're going to evaluate residents on milestones, then we better teach them what we're evaluating them on. And an example was that buy a new piece of equipment. And this year, when I made faculty practice doing milestone evaluations, I made my little clinical competency committee practice, because we have to do it in December. And they're like, I don't know what to say about this. And I said, yeah, because I don't think we teach it. We certainly don't evaluate how the residents learn it. So whether that's a business school model where they do sort of a modeling thing, and like, you want to take over Apple? Okay, here's the data. Let's see, can you take over Apple if you are Microsoft? And maybe that's the way we have to do it, because they're just not going to be able to do it in a real-time fashion. But anyway, I want to allow time for questions, so I'm going to stop talking with just recognition of my program coordinator, Amanda, who's fantastic, the faculty who either enjoyed or suffered through this experiment, and the chief residents when we did it, and this year when we changed it, who got all the crap from the residents. The residents were kind of mad about changing Superblock, and many of them said, this is why I came here, why are you screwing this good thing up? So I hope we didn't screw the good thing up, but we'll see. But you can't have Nathan Charles back anyway, he's going to stay. All right. Michael.
So, I mean, it seems like a really innovative concept. I like the idea of trying to teach people consultations. It's kind of like Robin and I were training at the University of Washington. It's a big part of our practice. Lots of call. But how do you evaluate residents? I mean, you have a 3-month block. You have tons of different teachers. Who actually fills out the evaluation? Is that a cumbersome process?
That's a really good question. Everyone was signed evaluations, and so the presumption was that they were evaluating kind of, when I had the residents in, so Elliot Williams, when I had them in my co-ed group and they were supposed to present, you know, antiphospholipid testing and how we do what, they did a good job or a poor job. In some cases there were actually some, you know, objective exams and stuff in certain areas, so and then their presentations for Thursday morning, that was what we evaluated. We have switched, like many places have, this year to a milestone-based evaluations, and instead of having a generic evaluation for any rotation, which is kind of what I wanted before, now you really can't do that, because certainly a search path person looks at it and says, I can't say anything about they did, you know, quality control in the lab. So now so all the rotations are going to have their own milestone-based evaluation, and then the people involved evaluate. And if they can't answer the question, they can't answer the question. That's okay, I guess. John?
Erik, I really enjoyed that, and I want to emphasize that pathologists are actually physicians. Believe it or not.
Yes.
Pathologists are actually physicians, and it's very difficult to teach pathologists what they're going to need to do in CP in an academic center, because if they go out into the real world, they're dealing with a much different block of clinicians than they are in an academic
Absolutely.
center. And as we're changing medicine over the next many years, many more primary care docs will actually be taking care of patients than they are now. And so I find this very difficult, because we are not getting the pathology residents really involved in taking care of patients.
I completely agree with you. So like, for example, when residents are with me on HemePath, if you write clinical correlation is suggested, I will beat you senseless. By whom? By you. You're the clinician, you idiots. You know, and I think John's exactly right. And I talked to a couple of colleagues of mine a couple of years ago at a meeting who were residents at Stanford with me, and they were in private practice in central sort of coastal California, and they were telling me these stories about, like, yeah, we're the only people in the hospital who know anything about anything.
Right.
Like, everybody calls us and says, you know, what's cancer? I mean, the stuff they were telling me, like we have to write the reports really simple, you know, so we can't use big words and stuff. And the same thing was true in the clinical pathology, let's say, realm, that they were getting they didn't have, you know, the world-class immunologists that you guys have abundance of here. And so no one understood what ANA meant or what was, and so presumably that falls to us. Oh yes, you know, everyone's personal statement says I want to be the doctor's doctor, right? Well, so I'll take suggestions. How do you teach that in an academic setting?
It's very hard.
Mike Linden, you have an idea?
No, I mean, I think based on the experience that like Robin and I had, and they had a, part of it is it was, since CP was a separate department.
Yes.
You couldn't have the AP, you couldn't be called to do anything on AP because you were just completely removed from that.
Right.
And I think that they developed, I mean, we complained about it, maybe you didn't complain about it, but we had CP call, it was really, really intensive. And the way that it was set up is all the CP faculty were around the perimeter, all the residents were kind of in the center, and kind of this, it was kind of a lowbrow, cubicle type environment. But you were, you know, when you were on call, you were getting 10 to 15 calls a day to basically figure out, you know, approve this send out, interpret this one-to-one mix, interpretation of laboratory data.
I think that's great, but that's a little different. But the people calling you were presumably mostly University of Washington physicians.
Well, the thing is, but they had this reference lab, so a lot of times we were providing specialty testing for 5 states. You get someone calling from Alaska.
Well, that's, yeah,
That
if
may
you
be
have a
saying-
reference lab, then that's a different story.
Right.
And I don't know
for,
how, I mean,
for chemistry, each person was required to basically bring a test online. So every one of us was assigned a project. And so
that sounds like it's a good thing for medicine. Let's make some more tests. Come on, kids.
No, but I was at the VA, for example, and they didn't do quantitative immunoglobulins, and so I brought quantitative IgG, IgA, and IgM online.
Which
So I
seems
had to,
reasonable enough.
you know,
Yeah,
we
but that's a good
learned
experience.
I didn't bring up a new test, I just fixed an old one.
But same idea.
Yeah.
Yeah? Oh,
so-
sorry.
So it seems to me that you're trying to solve a problem here of breadth versus depth. You're trying to, when you schedule bigger blocks of time, you get a nice uninterrupted chunk of time, but you can have them less frequently. Somewhere, there's a balance between having a year at a time of year of CP, year of AP, year of CP, and having the way that you had it before you brought in these changes where it's like ACCP, all mixed up together. Do you have a thought for what sort of the optimal block of time is that people should be doing CP? And with having shortened your super block now, would it make sense to sort of re-lengthen it by always appending a heme path block onto the end of it, or always appending a chemistry or micro block onto the end of it, so that you still have 3 months of doing CP?
I kind of think that would be optimal myself. Then I go to the chief residents who are trying to put that puzzle together every year. Oh, well, so-and-so always wants this and this, you know, so then it gets to be very, and actually one of the things I didn't even think about when I changed this, like I like the idea of, oh, I'm going to trick those autopsy people and they're not going to be able to do this.
Yes.
But then all of a sudden the chief residents had this chunk that they had to put in and they didn't have like leeway. And so there's a lot more residents saying, why did you put me on surge path following out? You know, now I'm getting killed. So it makes it hard, but I agree. To me, one of the
And when I hear that, I want to sort of throw my hands up and say, geez, let's just do a year at a time, because that way you really don't have the problem. But then you have the whole going for a year without doing any CP problem.
or yeah, and then they come back to surge path and they're like forgot, you know, I don't know what's best there, to be honest. I don't know.
Eric, so like Michael said, this I think is really something kind of innovative, and I give you credit for doing something that no one's really thought of in this challenging space of educating in CP. So to the pushback you got from blood bank in particular, are there fellows in blood bank, and if they aren't, would you think that might change how the blood bank people might feel about this?
Yeah, good question. So we did have a transfusion medicine fellowship, but for reasons of just sort of when Jim Malter
Yeah.
was director of blood bank and director of fellowship, he became chair at UT Southwestern, and we didn't, by just the rules of ACGME, Nick couldn't be fellowship director. So then we had a part-time and so the ACGME was not happy, and then she didn't do a real great job of like crossing the T's and dotting the I's when the team came, and so we had to sort of temporarily suspend it. Now we're going to put it back. Now that Tom's here. So I think yes it would, but Nick and Tom both are products of Iowa, and they would say, oh yeah, yes, you have a fellow, of course, but the residents are always engaged too. So they would want the same thing even with the fellow.
I see.
They wouldn't worry so much about vacation and stuff because they say, oh, the fellow will handle it. Remember?
So first of all, I want to thank you for coming to a bastion of clinical pathology and talking about clinical pathology, because it's very brave.
And there were no vegetables at all, or donuts, or
Exactly.
anything.
And secondly, I want to say that the literature in medical education now, which predicts success, at least at the medical student level, is all about longitudinality and repetition and integration. And pathology, strangely, is very resistant to that. And I think that's what you've tried to do. You've built teams of residents, but not teams of faculty, which probably should be done. And you've moved them through longitudinally, bringing them back to the same topic, hopefully with increasing levels of knowledge every year. And pathology has always thought of ourselves as independent blocks. Well, you can't be a chemist if you're a microbiologist, but you mush it all together in practice. And so I think we would benefit, all of us as pathologists, from a little more mushing and a little bit less. And so I'm sad that you divided up a great experiment now by moving
I am
back
too,
into
but-
these individual blocks again, because I think you are going to lose some of the longitudinal revisiting. And you may get back that your resident is stupid because they're now back in their fourth year and they don't remember blood bank. So I really applaud your experiment. I think it was great, and I think some of us should replicate it.
Yeah, I sort of fear that you're right. I mean, I think in blood bank we have 2 really dedicated educators, so maybe they'll bridge it by just, having didactic sessions and keeping the residents, at board speed. So I don't worry too much about them, but I agree. And it's one of these funny things where ACGME says, oh, the program director should decide which faculty get to teach residents, and they should decide this and this and who gets hired. And I think, really? Or where's that title in my, I mean, I'm a vice chair, but I can't really do all that. And I could say, well, you're not teaching residents very well. If I say it to Kurt Reed, I don't think that's true of Kurt, so don't go tell him that. But if I say it to Kurt Reed, well, okay, well, so we're not teaching residents micro. So my choices are, we're doing it this way, or we have no residency program. I mean,
But I
tempting.
think the ACGME is right, and the clear visits are probably going to eliminate some hospitals. And there's going to be a lot of, if they really do what they say they're going to do, because the hospitals right now, from their first clear visits, stink. And so we have to get brave enough to say, this faculty member, this hospital is not good enough to train the future physicians of this country. And just like, this faculty member generates X amount of dollars, but they don't care about teaching, let them generate X amount of dollars and not teach. And so it's hard to be a residency director and do that, but I think people who have more authority are going to have to do that. Or everything the ACGME is doing, which I happen to really like in most of it, not all of it, is going to be for naught, and we will lose an enormous opportunity in medical education. And at least at the small level of medical student teaching, if we ever get enough faculty, I'm not going to let people who don't want to teach, because it's not fair to the students, and they pay a lot of money.
Yes, that's been my approach
Yeah.
in my educational as well. Like, you don't get to do this.
No, exactly.
Yeah.
It should be a privilege.
Right.
Tony, did you have one final question?
There's,
Well, just sort of a general comment, I think that I prefer the term laboratory medicine to clinical pathology. I've always sort of wondered about clinical pathology, like is there some pathology that's not clinical? But
yeah.
Our
Agreed.
histories, we came out of internal medicine, at least in this department here. We were originally 2 departments, lab medicine and pathology, which is why we have this weird double barrel name. But our connection has to be with the clinical services. We are the bridge between the clinical services and the lab. There are 300 tests, you say, in chemistry. The clinicians are faced with thousands of tests they can order. They don't understand what these tests are about. They don't understand the nuances, the subtleties. Outside their very limited domain of their specialty. That's our job. That's what we're supposed to do, is to bridge that gap as physicians and explain how this test applies and can be used for this patient, what the interpretation is, what it means in a clinical context. And it's not about, and actually the thing about the electrode was sort of interesting, because we actually switched from a sodium electrode that was a direct ion specific electrode to an indirect ion specific electrode a month ago. You think, oh well, that's kind of arcane. Suddenly pseudohyponatremia is a real problem in our patients, because the indirect ion specific electrode is susceptible to interferences by hyperlipidemia. We had a patient who had that recently. So that's the kind of stuff that we need to know and put it into a clinical context.
And the kind of stuff that resident needs to see in real life.
Yeah, if the residents are just sitting in the lab, they're missing laboratory medicine.
Agreed. Okay, thanks.
Eric, that was terrific. I actually think what you're doing is great. I really love the idea. The analogy you made with APS, they're always coming back to it and they accumulate. I think it's not simplistic, but it's exactly what it's about. You just see it in the residents. Their eyes glaze over when they're in their fourth year and they had something in their first.
Right. And they think, sounds sort of familiar.
I'm going to push on to this. Is really, I really appreciate it.
That was great. We're going to meet later. I'm trying to Dr. Lassie.
I'm going to try to get you.
Okay. Thanks also.
Yes. I did. I saw her last week in the car.
Correlation required. I was a lab tech, actually down in Mayo.
Okay.
That went on every single floor.
I know. And it's like, and he's in radiology the same thing. And in Mayo, so to defend Mayo in a way, you can see if they got this chunk of tissue from Tuscaloosa.
Oh, no.
And they can't look at the record. They don't know anything about the patient. All they know is what the patient. Okay, I understand then you say, okay, well, I don't know if there's a story. You get to correlate it, but you're in my hospital and you're doing the record's right there.
Yeah.
You know, you can find out just about everything you want to know, or you call the person and ask, and then write your conclusion. So,
Yeah, I mean, 90% of the tests we were doing were reference lab tests. So